Hello and welcome. So glad you can be here with us today. This is our UNC Cancer Network Med-Surg Oncology lecture, today May 27th, 2017. A few preliminaries before we get started. If you are having any trouble with viewing this at any point during the lecture today, you can email us unccn@unc.edu. You can call or text us at 919-445-1000. We'll be using Poll Everywhere in just a minute, and we'll talk about how to use that so that you can both join for the first question and then do Q&A at the end of the presentation. Check us out on the web at unccn.org. We're on Facebook, we're on Twitter, we're on YouTube, lots of places you can find us. So welcome. I mentioned Poll Everywhere. You can either go to pollev.com/UNCCN, and that's an easy way to find us and then respond. Or if you have a phone, any phone that can text in front of you, then you can just text the letters UNCCN to the number 22333. So you'll start the text 22333, you'll put in the letters UNCCN, then you'll get a response back that basically says join, you've joined the session. And then in just a moment, you can go ahead and respond to our first poll question, and that will be, according to research, whose reports of symptoms better reflect true patient health status? Is that A, patients? Is that B, clinicians? Or C, not sure? And if you're not sure, then I think you'll know more after today's presentation. All right, so with that in mind, I do have a disclosure statement. This activity is planned and implemented under the sole supervision of Thomas Shea, MD, the course director, in association with the Office of Continuing Professional Development. Thomas Shea, MD, consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. CPD staff have no financial relationships with commercial interests. The speaker, Ethan Bosch, MD, MSc, does not have any financial relationships with commercial interests. Let me go ahead and move the camera so that you can we can have Dr. Bosch on as well. And welcome. So glad to have you here today.
Great to be here. Thanks.
Our presenter, Ethan Bosch, MD, MSc, is a professor at the University of North Carolina at Chapel Hill and holds dual appointments in the Gillings School of Global Public Health and in the School of Medicine. He is also director of the Cancer Outcomes Research Program at the Lineberger Comprehensive Cancer Center. Dr. Bosch is a fellow with the American Society of Clinical Oncology and associate editor for the Journal of the American Medical Association. He also has appointments to the Board of Scientific Advisors with the National Cancer Institute and the Federal Methodology Committee for the Patient-Centered Outcomes Research Institute.
It's a mouthful.
That is a big mouthful.
Yeah.
So let's keep it simple with this next one. You're going to be talking about patient outcomes and the role they have in treatment of patients and the responses from those patients. What led you to an interest in this?
Sure. Thank you. It's a great question. So, so I'm an oncologist.
Okay.
I see patients with cancer, and I also do clinical research. I work on the development of new treatments in cancer. And years ago, when I was a young faculty member, it became clear to me in a number of our trials that we really were not capturing the symptoms and the side effects that our patients were experiencing. I remember there was one particular early phase trial in prostate cancer where we were sitting around the table looking at the side effect results from that study, and there were almost none. But we all knew that almost every patient went off of that study because of severe fatigue and nausea. And I started to scratch my head and think, what is going on here that we are missing this essential information about how our patients are experiencing their cancer and their treatment? And that led me down this road, and now 10, 15 years later, here I am, having done a fair amount of work in this area to try to get under the hood of why we miss so many of our patients' symptoms and side effects and how we can bridge that gap.
Great. Well, we're very thankful that you're doing this work and looking forward to hearing more about it. Let's find out from our audience how they did with this first question. So looks like in terms of who reports better symptoms that better reflect true patient health status, it looks like we're trending with A, the patients right now.
I should pack up and go home because my work is done. Although we have 13% who are thinking that clinicians are perhaps the best source of this information, and while they're a very valuable source, I'm going to provide some data to suggest that perhaps the patient is the best source. But we'll look at the science and then we can decide.
Great. Well, that's a good place to start. And with that in mind, I'll go ahead and turn controls of the presentation over to you.
Terrific. Well, thanks so much, everybody, and thank you for the invitation to be here today. I'll be speaking about what we call patient-reported outcomes for symptom monitoring. And for those of you who don't know, patient-reported outcomes are essentially reports of anything that patients are experiencing around how they feel or function. This would include symptoms, physical functioning, and quality of life. It doesn't really include metrics around what we call patient satisfaction, things like did the care team call you back over the weekend when you called with a problem. It's really more about how people are feeling and functioning. And there's been a tremendous amount of interest recently in asking patients to self-report their own experiences of their symptoms and their functioning during treatment for chronic illnesses, particularly in oncology. And I'm going to provide some of the data around that for you today. I think before I start, it's helpful to provide a framework around what we call health services research, or the kind of research we do to understand the best way to deliver care. And we start by noticing a problem and then go all the way through this continuum of characterizing it, trying to develop solutions and testing them. And then we move all the way to trying to implement a solution to that problem. And I'm going to take you through this whole continuum around patient reporting of symptoms in oncology. And we start with the problem. And this is the problem. This is what we call the straight line phenomenon. This is an old school paper chart like we used to use back in the day, not that long ago. And doctors and nurses fill these out for patients. Sometimes we call this a review of symptoms or the review of systems. We routinely include this in our EPIC notes. And here we evaluate the patient's health status, and often this information has to be drawn from the patient, and then we record it. And we call this the straight line phenomenon. This is the phenomenon when I or one of my colleagues walk into a room and we see Mrs. Jones and we say, "Mrs. Jones, how are you doing?" Mrs. Jones says, "I'm doing great." And I say, "Terrific." And I go straight down the line. And that's as far as this interrogation goes. There's not in-depth evaluation of these symptoms. And this is a problem because in oncology, as we all know, it is essential to understand how our patients are feeling and how they're functioning, because that is the basis for many of our clinical decisions and interventions. And this problem raises some research questions. The first is whether clinician symptom monitoring adequately captures the patient experience, right? When I walk in the room and I eyeball Mrs. Jones, am I really understanding how she's doing? If not, how does this impact the care we deliver? And are there alternative approaches to symptom monitoring that can improve quality of care and outcomes? And I think it's helpful to take a look for a moment at the standard way that we report symptoms in oncology. This is true both in oncology practice and in oncology clinical research. We use the CTCAE, the common terminology criteria for adverse events. This is what we call a lexicon or a library of items that's maintained by the National Cancer Institute. There are about 800 items in the CTCAE, about 10% are symptoms, and this includes anything ranging from something very symptomatic like fatigue, which is very subjective, all the way to something very, say, objective, like malignant hypertension or retinal detachment. And the CTCAE is maintained by the National Cancer Institute, and again, it's widely used in oncology. At the bottom of this slide, you see an example of a CTCAE item. This one is for mucositis, and we see going across the top of the criteria individual grade levels, and then down below the clinical criteria that are anchored to each of those grade levels. If you look for a moment at CTCAE grade 2, it's defined as moderate pain, not interfering with oral intake, and modified diet indicated. This includes an evaluation of severity, right, the moderateness of the pain, of interference with functioning, right, it's not interfering with oral intake, and then a clinical judgment, whether modified diet is indicated. This is a complicated construct and is difficult for anybody to piece together, and I'm going to get to some of the difficulties with these criteria as we move through. But I think the important take-home message here is that this information is reported by clinicians, not directly by patients. So I need to figure out if all of these criteria apply to my patient in order to grade the CTCAE for my patient. So back in 2002, we developed an initial patient version of the CTCAE. Again, the standard way this is done is clinician reporting, so it was an innovation for patients to self-report. And we started to test this, and we called this version for the patient STAR, for symptom tracking and reporting. This is the old school web site that we used, again developed in the early 2000s. This was a Web 1.0 application. It was used on tablet computers in clinic waiting rooms, and patients could use it from home. You can see this is an example of the fatigue item. And the first question that we asked is whether patients and clinicians agreed with each other. So if I and my patient evaluated these symptoms at the same time, would we agree? And so we did a study of 400 patient-clinician pairs during chemotherapy, and we administered analogous CTCAE symptom questions to them at their clinic visits. And this is what we found, and I'll walk you through this. So each of these bars represents an individual symptom. You can see starting from the top, fatigue, then pain, constipation, diarrhea, and so on. Within each bar, you see different gradations of grayness. The lightest bar in the middle shows the proportion of patient and clinician pairs for which there was absolute agreement about the grading of that symptom. So you see for that very first bar, fatigue, 41%. Is shown in the lightest area. That means that 41% of patients and clinicians agreed with each other. If you look over to the left, where it then says 34% for fatigue, those slightly darker bars show the pairs where the patient graded worse, graded 1 point worse. And then the even darker bar shows where they graded 2 or more points worse. And you have to think about the criteria, right? There are only about 4 grade levels, so a 1 or 2 point difference can actually be a big difference and can be the basis for making a change. For example, a chemotherapy dose modification. So on the left side, as the bars get darker, that's where the patients graded worse. But on the right side, that's where the clinicians graded worse. And so the take-home messages here are, first of all, the agreement's not that great. 41%, 60%. If you go down to dyspnea, 52%. Patients and clinicians are not agreeing with each other much of the time. But the other take-home here is that the bars on the left side are thicker than the ones on the right, demonstrating that in cases of disagreement, it's more common for the patient to grade higher. In other words, we as clinicians are downgrading what our patients feel that they are experiencing. And so we became interested in the cumulative impact of this. What is the impact of this over time? Let's say that we're following patients for a year or for 2 years. And so we did this study in about 800 patients and their clinicians, where we had patients and clinicians report their own symptoms over time. The patient report is shown in orange, the clinician report is shown in blue, and this is shown for a host of different symptoms. And what we see here is that over time, we as clinicians are missing or downgrading many of our patients' symptoms. If you look, for example, at the top at fatigue, we're missing a good proportion. That space between the 2 lines, those are all of the cases of fatigue that we are missing. And this extends across all different symptoms. Now, whose report is better or truly reports the truth? This question was posed to me and my colleagues numerous times, right? People, particularly clinicians, would say, well, you know, we understand that the patients are grading higher and we're grading lower, but, you know, we as clinicians, we really understand these symptoms. We understand these symptoms even better than our patients do. And that's because we as clinicians understand the full continuum of symptoms. My patient, Mr. Smith, thinks that his nausea is really terrible, but he should see Mrs. Jones down the hall. Her nausea really is terrible. His nausea isn't that bad. I'm going to downgrade Mr. Jones to mild, even though he thinks he's severe. And so the question was posed, well, whose view really reflects the truth? So we and others did a host of studies where we had patients and clinicians self-report, and then we measured a whole bunch of different what we called anchors. Put people on treadmills, had them breathe into spirometers, did swallowing tests, did measures of health state to see whose estimation of symptoms were more highly concordant with those underlying anchors, the patient or the clinician. And what we found was that across the board, the patient report was more highly concordant with the underlying metrics. Here we see a comparison of the patient and clinician reports as they correlate with an underlying measure of global functioning. And for each of these symptoms, we have an orange and a blue data point. The orange data point is the patient report, and the blue, the clinician report. The farther over to the right the data point is, the more highly concordant it is with that underlying measure. And across the board, we see that these orange data points are farther to the right, showing that the patient reports are more highly concordant or more highly reflective of the underlying measure of health status, suggesting that the patient report is a better approximation of the truth of the patient's true health status. What's perhaps more indicting is this evidence from Thomas Atkinson at Sloan Kettering. He did a study where he looked at clinician reports of patient symptoms done at the same time but blinded to each other. This was a study in which patients coming in for their chemotherapy saw one clinician for a toxicity check and then went to their chemotherapy appointment, and a second clinician did a second toxicity check. And they each independently graded the patient's symptoms. And then we looked simply at the agreement, and that's shown down the middle in that column called the ICC, which means the interclass correlation coefficient. This is a measure of agreement. For very reliable information, we would like to see these numbers being as close to 1 as possible, 0.7, 0.8, 0.9. But unfortunately, these ICCs are much lower. They're more in the 0.5 range, suggesting that when I and my colleague, or when you and your colleague, see the same patient at the same visit, that we don't necessarily agree with each other. In fact, we disagree with each other about half the time. And so this is a problem for clinician rating of symptoms. It suggests that we are not optimally reliable in our estimation of patients' symptom burdens. So the next question that was posed to us, well, that's all very well and good. We clinicians aren't great at it, but at least, we're not as good as the patients, but maybe we're pretty good. The biggest problem with getting this information is actually getting it, right? And our patients, they're too sick. They have a lot going on. They may not be comfortable with questionnaires or technology. We bet the patients aren't going to report this. And so a number of studies were done looking at what we call the feasibility of patient self-reporting. Are patients willing and able to self-report their own symptoms during clinical practice and in clinical trials? It turns out that in clinical practice, about 80 to 85% of our patients will provide this information to us at any given time, either from home or from clinic. This has been shown with numerous different electronic formats and with paper questionnaires, but most of this has been done electronically. Through handheld devices, through the web, using automated telephone systems. And in fact, in clinical trials, it's even higher. In clinical trials, the compliance of patients is about 95 to 100% if this is done well. So a little bit lower in clinical practice, around 80%, and higher in clinical trials. What people have had interest in is what's called the collaborative model of reporting, which means that our patients come in and they report their own symptoms, and then this information is conveyed to us in near real time for us to make clinical decisions or to make clinical research decisions. And I'm going to show you one example. This is an example from a phase 2 clinical trial, but this system can be used in any context, including in clinical practice. And in this study, an interesting thing was done. About half of the patients in the study self-reported, and the information was conveyed to their clinicians in real time. And for the other half, they reported their symptoms electronically, but then their clinicians didn't see it. And I'll take you through a little bit of this. So this shows a computer interface that was used by the clinicians. So the nurses and the doctors used this interface. And what this interface did was it showed them what their patients had reported. So the patients came in, they self-reported using that system that I showed you earlier, and then that would be conveyed to the clinicians. The clinicians down the left side would see all the different symptoms their patients reported. Then in the next column, they would see the grade of that symptom. So you can see for this particular patient, they didn't have that many symptoms. They had no alopecia, grade 1 anorexia, grade 1 cough, grade 1 dyspnea. And then if you move to that agree column, a couple of columns over, the clinician then had the opportunity to agree or disagree with the patient. So you can see down here, this clinician is changing the grade for fatigue. The patient said grade 0. The clinician's changing it to a grade 1. And what we did in this study was we then looked at whether this changed the level of agreement between the patients and the clinicians. So first we looked at those clinicians and patients in the cases where the clinicians did not see what the patients had reported, and we found that the level of agreement was still lousy. It was still similar to that initial bar I showed you. About half the time there's agreement. But then we looked at the cases where that computer system I showed you was used, where the clinicians saw in real time what the patients were reporting. And lo and behold, we found that the patients and the clinicians agreed with each other almost all the time, 93% on average, suggesting that if you or I see what our patients are reporting, we tend to agree with our patients. We went back and we talked to the clinicians about this. We said, did you agree with your patients because you were lazy and you just didn't feel like disagreeing? Or did you really think that what the patient said was valid? And universally, the clinicians fed back that they found that the patient information was valuable and could be used as the basis for clinical decision making. So around this time, the National Cancer Institute became quite interested in work that we and others were doing in this space, and they decided that they wanted to create a patient version of the CTCAE called the PRO-CTCAE. And our group led this effort, although we led this with a consortium of about 20 other institutions around the country. And in this project, we developed a very robust library of patient-reported questions representing the CTCAE items. We created software to administer this, and then we tested the way that this system functions. We first looked across the CTCAE, and as I mentioned, we found that about 10% of the CTCAE items represented symptoms, things like nausea, vomiting, diarrhea, constipation, anorexia, myalgias, arthralgias, the subjective experiences that patients commonly experience during cancer treatment. And we developed items for the patients to answer. So we started with this. This, again, is the clinician version of the CTCAE that many of you are probably familiar with. But we converted this into a different approach for the patients. We split it up into its different constituent concepts. We asked patients separately about severity, about interference with daily activities, and about the frequency of those symptoms. As you see here from mucositis, it was broken into two items. What was the severity of your mouth or throat sores at their worst? And how much did your mouth or throat sores interfere with your usual activities? And then you see over on the right the very simple response options that patients have: none, mild, moderate, severe, very severe. And then we map this back to a CTCAE grade. This shows software that was developed for administering these items. This is what we call an item library, where a clinician or an investigator can go in and select from this library just those items of interest. So if there was a clinical context, say patients with gynecologic malignancies where specific symptoms are of most interest, or a clinical trial where particular symptoms are of interest, one would just hone down on those particular symptoms. Calendar can be set up. This can be synchronized either with Epic or with a clinical trial database system. And then this shows the questionnaire more updated from that one I showed you at the beginning. This design was actually created by what we call a human factors consulting firm on Madison Avenue in an all glassed-in building. These are the folks who develop graphics for major corporations, and they did quite a bit of usability testing in patients. And then this system is also available through automated telephone systems for patients who either lack literacy or lack dexterity, don't have access to a computer or a handheld device, etc. The system can send automated alerts to nurses or doctors or others about problems that patients are experiencing. For example, this patient was having severe tinnitus, and they reported it from home. It looks like this was a patient at Duke, and so the system automatically triggered an alert to that patient's clinician about this problem. The system and the questionnaire was extensively tested, first in patients to make sure they understood the questions, including those with lower education in a very diverse population. And then there is what we call a validation study done to look at whether the questions are valid and reliable, sensitive to changes over time, all of the characteristics of a questionnaire that we consider to be important to consider it to be a high-quality questionnaire. We also looked at feasibility and found that across cancer clinics and contexts, both in routine care and in clinical trials, that the vast majority of patients are willing and able to self-report this information. Generally, patients have to be reminded to do this by either the clinic staff or the research staff, depending on the context of the use of it. If they're not being reminded, they generally won't do it. If they feel the information is not being used by anybody, they generally will lose their enthusiasm for it. But if this is really integrated into the way that we're conducting care or research, patients are generally quite enthusiastic to do it. This is the website for the PRO-CTCAE from the National Cancer Institute. If one wanted to use this questionnaire system either in a clinical trial or in clinical practice, one could simply go to the site and download it. I'm going to give an example from a clinical trial. I know that I've been focusing a little bit on clinical care because of the audience today, but these tools are of great interest in clinical research also, and I think it's a nice illustration of the power of patient reporting of symptoms. This is an example from one particular clinical trial where this patient version of the CTCAE was used. This was a trial comparing cabozantinib, which is an investigational agent, or it was at the time. It's now actually widely available for a couple of kinds of cancers, including thyroid cancer. In this study, it was compared to mitoxantrone, which is an existing therapeutic for prostate cancer, and this was, in fact, a study in metastatic prostate cancer. 10 patient-reported CTCAE items were selected. These were reported by patients every 3 weeks from home, between visits using an automated telephone system. And if they didn't report, then they'd get a call from a human saying, are you all right? Why didn't you report? You can tell me now and I'll write it down for you or record it in the system, or you can just go and report it yourself. And on average, 96% of patients self-reported this information at each time point where they were expected to do so. So this is a busy slide. I'm just going to use it for an illustration of how the patient-reported information can be used. These are classic toxicity tables. These are reported in clinical trials. They're in every drug label, and this shows how the patient information can be integrated. And everything that's shown in red is statistically significant. And in fact, when we looked at the number of statistically significant symptoms, or in this case, adverse event symptoms between arms, none of them were significantly different between these study arms and reported by investigators, but 3 of them were when reported by the patients, showing that the patient report has greater precision. It has greater ability to delineate between the study arms in this case, or in the case of clinical care, better ability to identify underlying stuff that people are experiencing, better than we as clinicians do. This is another way that this information can be used. This is showing over time across a population what's happening with a particular symptom. These are vertical histograms. Each of these bars shows the distribution of severity of a particular symptom. I'm showing you here the symptom of appetite loss or anorexia, and the lightest shaded bar is the lower grade or the low severity, and then as they get darker, there's more severity. So just as an example, if you look at that very, very first bar on the left, you see there's a distribution where there are patients who are having every grade level, the least amount for the grade 4s, the most for, let's say those grade 2s, but people are having all of these symptoms. And what's helpful here is that, first of all, if we look at what we call screening or baseline before anybody gets their drug, you see that almost 80% of people are experiencing this symptom. Patients are very symptomatic even before they start drug. In clinical trials, we often fail to appreciate or capture this. And what you see is with the cabozantinib arm, right, that first group of histograms, you see that over time, there's no decrease in anorexia. If anything, there's worse anorexia over time. But if you look at mitoxantrone on the right side, even though a lot of people start with anorexia and they continue to have anorexia throughout, it goes down, suggesting that actually people who get mitoxantrone have a better appetite loss experience than those who are receiving cabozantinib over time. So what about use in routine clinical care? I think that's perhaps more germane to the talk today. There's actually interest in the UNC health system to integrate patient-reported outcomes into how we administer care to our patients. This would mean that patients with chronic illnesses, including cancer, might regularly be self-reporting their own symptoms, and this would go into Epic and might trigger alerts to us that would go to our in-baskets for patients who are experiencing severe or worsening symptoms. I'm going to show you some of the evidence to show that this is actually beneficial. Now, there have been multiple studies showing that electronic patient-reported outcome capture systems used in clinical care can improve communication between doctors and nurses with patients and also improve our symptom control, our symptom management. I'm going to show you one particular randomized trial that was done at Sloan Kettering in about 750 patients, actually 766, in which patients receiving chemotherapy for solid tumor malignancies were randomly assigned either to self-report using one of these types of systems that I showed you, or to standard symptom control, right, standard symptom care. Those patients in the self-reporting arm reported 12 common symptoms: fatigue, pain, nausea, vomiting, diarrhea, constipation, dyspnea, mucositis, both at their visit, so in the waiting room before they saw their doctor and nurse, and between visits by computer. And when they experienced severe symptoms or worsening symptoms, it would trigger an email to their nurse saying, Mrs. Jones is having severe pain, you might want to give her a call. And then in this study, a whole host of outcomes were looked at, including the quality of life of those patients, the symptom control for those patients, ER visits, hospitalization, and in fact survival as well. So the first finding was that overall about 80% of patients self-reported at any given time. That meant that if you or I had a patient who was doing this, about 80% of the time that patient would self-report. Or across our whole population of patients at any given time, about 80% of our patients will be self-reporting. And this had great durability in this study. And this included even patients who were very ill with a high symptom burden, even patients very close to death. Nurses responded with clinical actions 76% of the time to these email alerts. That meant that the nurse called the patient and gave symptom management advice, prescribed new medications for nausea or for constipation. In some cases, the patient was referred in to a new clinician or even to the ER. It was found that patients' quality of life substantially improved. 31% of patients had better quality of life at 6 months and again at a year when compared to baseline for the patients who had the patient-reported outcome intervention, meaning that 31% more patients had improvements. If you look at this figure, when comparing usual care to patient-reported outcomes, the green shows the proportion of patients who had improved quality of life. With usual care, 18% had improved quality of life, while 34% with the PRO had improved quality of life. Again, if you look at usual care in the red, 53% had worse quality of life at 6 months, whereas with the PRO intervention shown on the right, only 38%. So again, 31% of patients overall had better quality of life compared to usual care when they self-reported symptoms. We then looked at admissions to the ER and found that over time, there was a reduction in ER visits. In fact, 7% fewer patients visited the ER with the patient reporting than with patients who are receiving standard care, with a similar finding with hospitalization. Fewer patients were hospitalized. About 4 to 5% fewer were hospitalized with patient reporting. The study also looked at overall survival, and this is being reported as a plenary presentation at the ASCO meeting in about a week in Chicago. So this result is embargoed until about a week from now, but is slated to have quite a bit of coverage. What's happening now? So our group is leading a national study looking at patient reporting in routine oncology practice to see if this is feasible very widely, if we can integrate it into practice, and again to look at the potential clinical benefits of doing this. This is a study in about 1,000 patients at sites nationwide. And we're also looking at the use of patient-reported outcomes for quality assessment. So, for example, to evaluate whether across an enterprise or within units within an enterprise, if we're controlling symptoms as well as we should be. For example, are we controlling nausea following chemotherapy well? Are we controlling pain in patients who have metastatic bone lesions well? And across clinicians or even within the individual clinician, how well are we doing? And is this an opportunity to use the patient-reported information to identify clinicians or clinics where we could do a better job? So what about at UNC? So at UNC, there's something called the ProCore, the Patient-Reported Outcome Core. This is a unit that's supported by the Cancer Center that can create patient-reported questionnaires for use in all different settings. It can be used for your clinic. It can be used for your clinical trial. The faculty director for the ProCore is Antonia Bennett, who's in the School of Public Health, and the lead programmer is Matthias Johnson. There's an ongoing effort to integrate patient-reported outcomes into EPIC. This is being led by Carol Lewis, who leads the UNC Hospital Systems Innovation Center, and Angie Smith, who's in the Department of Urology, is leading the implementation of this. And for anybody who would be interested in being a part of this implementation effort at UNC, please feel free to reach out to me or to Angie Smith. She's on the UNC email system. We'd be delighted to have you involved. There's a tri-institutional regional feasibility project through the CTSA. This is a partnership between UNC Duke and Wake Forest. Recently, MUSC has also joined, and this is an implementation project to integrate patient-reported outcomes into EPIC at these different institutions, and then to pull those data from our respective data warehouses. And there are multiple studies of wearable devices ongoing now. There's a lot of interest in patients using Fitbits or Garmin devices to understand how well they're functioning, to see how their sleep is, to see their physical activity, and this is being conducted by multiple different clinicians and investigators at UNC. And my email is down at the bottom. Again, anybody who's interested to collaborate in this work, we'd be delighted to hear from you. This is the homepage for the UNC ProCore, the Patient-Reported Outcomes Core. Again, this is a terrific resource for anybody who's interested to use patient-reported tools in their practice or in their research. So in conclusion, we're going to end a little early today. I was talking fast. I'm a fast-talking New Yorker by birth. In conclusion, patient self-reporting can enhance symptom monitoring in clinical care. It can improve our understanding of the patient experience with disease and treatment. It can engage patients in care and connect us with our patients between visits. But it also demonstrates how hard it is to change the way that we do things, even if it makes a lot of empiric sense. It makes a lot of sense to ask our patients how they're doing and to use these kinds of systems to monitor our patients in between visits when they're out of sight and out of mind and, as we know, often suffering. But it's exquisitely difficult to change workflow. It's very difficult to change technology. And we all know how hard it is to shift the way that we're doing things. And so now I think the really hard work, now that we know that this is beneficial to our patients and to how we interact with them, now is the hard work of actually integrating this into how we administer care. And I think that's the change that we're going to see in this area over the next few years. Thanks very much. I appreciate your time.
All right, Dr. Bosch, thank you so much. Let me open this up to questions. Remind everyone, you can go to polev.com/UNCCN, or you can just go ahead and start texting. If you've already joined earlier on joined our poll everywhere, then it's easy. You just go ahead and start texting your questions. If you haven't done that yet, a one-time text to the number 22333 with the letters UNCCN, that joins you to the conversation, and then you can text in your questions, and we hope you have lots of them. I have lots of them, so let me jump right in. Thinking back to when I was working my way through college and I worked in a movie theater, and I noticed that depending on what I asked the patrons there, I could get really different responses. If I just said, thank you, let them pay for their ticket, that was one thing. If I said, would you like anything to eat or drink, that elicited more of a response. If I said, and what would you like to eat and drink with this, then I could sell all kinds of popcorn and soda. Really made a difference just how I phrased those questions. What are the kinds of thoughts that go into designing questions for patients so that you elicit A, responses at all, and B, the most sincere, authentic responses from those patients?
Absolutely. It's a great question. So, I'm but a humble oncologist, but I've done quite a bit of work with collaborators developing patient-reported questionnaires. And in fact, there's a very robust and well-developed science around how to develop and how to test questionnaires. There are many important components. The first is, what is the underlying concept that we're trying to measure? And are the words that we're using in the question truly reflective of that concept? When we translate that concept into other languages, or we administer it in a very diverse population, does it continue to represent that concept? Whether you're from Greensboro, North Carolina, or from northern Canada, right. Do you always think that shortness of breath is the same thing? But then there has to also be some objectivity, I guess you could say, in the way the question is framed. And there's quite a bit of testing that goes into assuring that. Now, there's another interesting aside about the movies. It's a great example because movies are something that we rate all the time, and there are all kinds of websites like Rotten Tomatoes that we all often go to figure out if we want to go see a movie. Yeah. And what these sites often do is they'll aggregate all of the different professional movie reviews. Right? They'll go to the New York Times and the Washington Post or the News and Observer, and they'll aggregate these and normalize them and try to give you an overall score for what the reviewers thought. And then they let normal folks like us say what we thought of the movie. Yeah. And what's really interesting is that there's often a discrepancy between what the reviewers said and what we as consumers said. And, one could conjecture this is for all sorts of reasons, right? It might be the movie reviewers are looking at cinematography, or they're comparing it to the classics, and we just, we want to go out and have a good time and see a nice movie and, have fun. And I think that this discrepancy actually is applicable to this example, which is how clinicians and patients evaluate the same thing. We have a different perspective, and the reports are discrepant.
Okay. Well, and we see lots of questions coming in, so that's great. Please keep those as you think of additional questions, send those our way. To get the EPIC program to integrate with the ProCore would be terrific. Good luck. Yeah. Do you want to say anything about the challenges of doing that?
Yeah, so I'm hoping that that's an enthusiastic comment and not good luck. Yeah. Yes, I completely agree with that. So there's quite a bit of interest in this. In fact, EPIC already has a patient-reported outcome functionality in it. Part of the patient portal, part of MyChart, has a questionnaire you can push to patients. And in the next build that we're about to get, actually this summer of EPIC, that functionality is even better. It's still not as good as a standalone system that can be interfaced into EPIC, and that's what the ongoing work is right now. And thank you for the good luck. It's really the good luck to the EPIC programmers who are doing this, and hopefully you'll be hearing more about the availability of a PRO system. But again, you could do it now with EPIC. It's just not the most user-friendly system you could envision.
Gotcha. And we got some clarification there. That was definitely encouraging.
Oh, yes, thank you. Encouragement. Thank you very much.
All right. Regarding clinical trials, had it been considered that patients may underreport for fear of being removed from the study, and that the patient-physician disagreement may not be, I'm going to guess.
We lost the end of it, but I get it. Yeah, so this is actually a frequent concern. Particularly in clinical trials, there's a concern that patients may not fully disclose their symptoms for fear that they'll be dose reduced or taken off protocol. And in fact, there's anecdotal evidence that patients will do this. But it's been shown that unlike a face-to-face interaction, for example, if I have a patient who's on a trial and I'm asking about their symptoms and they may not fully disclose to me that they had severe fatigue or severe nausea, patients will actually disclose that to a questionnaire. For whatever reason, people will be honest in their reporting to an electronic or patient questionnaire in a way that they won't to their clinician. So it actually has been shown that in clinical trials, patients will disclose this information. The other piece of it, though, is that when we do this in clinical trials, we're often clear with patients that if they report a severe symptom, that will be a basis for a discussion with the investigator or with their clinician. They won't just automatically be taken off of the study. But I completely agree. I think it's a real concern. And if somebody truly doesn't want to report on their symptoms, it's going to be hard to get that information, no matter how we're trying to get it. But we do know that the questionnaires do a better job than the old-fashioned way of trying to elicit it at an appointment.
Okay, and I guess I would add as a follow-up, is there a tendency for patients to underreport for other reasons? For instance, is there a tendency to want to please the practitioner to a certain extent? You're working hard as the practitioner to help me, and do I want to come in saying, yeah, things are good, this is working, and can that or other factors influence underreporting?
Yeah, absolutely, it's a great point. That is actually a well-documented reason that patients may not disclose to their clinicians. Patients don't want to disappoint their clinician. Now, there's another side to this, which is the clinician. The clinicians don't want to feel that they are failing or that their patient is not doing well with the treatment. And so the clinicians tend to downplay what the patients report and in some ways actually tend to discourage the disclosure. So it goes both ways, but a dynamic is created in that visit in which symptoms are not discussed or disclosed.
Okay, good to know.
Yeah.
Is there a role in the UNC Pro initiative for employees who are not clinicians or investigators?
Send me an email. Let's see. I think we would have to see, but in this initiative that Carol Lewis has been organizing, spearheading. There are many different stakeholders from UNC. There are those who work with governance, or those who work with the EHR. There are those who from ITS, those from EPIC. So there are also administrative folks and clinic staff who are often the folks who work with patients and educate them. So absolutely, there's definitely an opportunity. Please just feel free to reach out to me.
Great, thank you. What are some of the ways to encourage physicians to use patient-reported outcomes in their practice and to use them in a consistent way that translates to improved patient care and outcomes?
Yeah, I think that's really the challenge. The question is about how do we encourage, it says doctors specifically. I think it extends to doctors and nurses and other health professionals as well. But we know that doctors are traditionally, I can say this because I'm a doctor, are the most refractory to changes in the way that we do things. There's quite a bit of resistance to changes, whether they're changes in EPIC or changes in workflow. And I myself am guilty of this. So, I understand the dynamic. I think it's hard. Creating any change. I think that there are several steps that can be taken. I think the first is to make it easy. The way this works in EPIC or in Cerner or Allscripts, which are the three major EHR systems in the U.S., the PRO integration is not smooth. It's not easy. And so I think the first step is making it easy. I think we all know from using the systems that we all use every day, if something to use in Outlook is easy, we tend to use it. If something is easy in EPIC, we tend to use it. So the first is technical. I think the second is that there needs to be a message from leadership that this is a high priority. It needs to be an institutional priority. We tend to change our behavior when our manager or our division chief or whomever tells us that this is expected, this is something to do. And I think the third is that people have to see that it's beneficial in their practice. I think they have to observe that when that patient-reported information comes to them, that it inspires a discussion, there's better symptom management, and there's a better outcome for patients. I think that does it too. But I think that, those are dependent on number one, which are really much more around the nuts and bolts of implementation, much less around the actual value.
Okay.
And so I think at UNC, we're going to need to see this integrated into Epic, integrated in a way that's intuitive and easy to use, and then we're going to have to hear from leadership that this is important. There is a population at UNC where there's already great interest in doing this, and that's within our ACO population in geriatrics. So many of you may know that recently UNC became a next generation accountable care organization in geriatrics. That means for a very large panel of patients who are now responsible for the total cost of their care. And with that, we've become much more interested all of a sudden in how people are doing in between their visits when they're at home, because if they're at home and they have a severe symptom and they roll into an emergency room, we are now on the hook for that cost. And so within that population, there's a great amount of interest in engaging patients in different ways between visits. And so we may see the first iterations of this patient reporting within the ACO population.
Okay, and let me follow up. And if you have other questions, please, we have a few more minutes, so we hope you'll send those in. Hopefully not to get too much into the weeds, but with that follow-up between visits, let's say as a patient, I start to report on my app that my symptoms are going way up. Is there anything within the algorithm or the code there that would then generate something that might ask me to report more frequently and to determine, okay, is this a trend, is this going to continue to go up or stay at a relatively high level, or was that a discrepancy, and if you ask me to check in, 5 hours later, has it gone back down to a less severe symptom?
It's a great question. So, it all depends on the system. There are lots and lots of different PRO systems out there. Gotcha. There are some systems that will simply pop up an alert that will say, you've reported a serious symptom, we've sent an email to your nurse, but if this continues to bother you, pick up the phone and call your doctor's or nurse's office or call 911. There are some systems that actually feed back advice. It says you've reported moderate constipation. Here are some things that you can do for your constipation. What most of the systems don't do is have some intelligence, like what you described, which is, for example, within the system itself, to look at the arc, the trajectory, or to check back in with the patient sooner, or to ask them a whole bunch of other questions that are related. Most of the systems are still pretty rudimentary. I think that moving forward, we'll start to see that kind of functionality that you described.
Great. And that, of course, then if somebody didn't respond 5 hours later, might prompt a clinician to reach out to that person.
That's right.
All right. Well, I think we're kind of nearing the end of our time. So, one more. Has there been any testing with respect to the timing of the questionnaires? For instance, is it more valuable to have hard and fast time points, or to have the patients complete these at will upon any changes that they may experience? It's
a great question. So, it all depends on the context in which it's being used and the purpose of the information, I think. So in a clinical trial, for example, it's very important that there is consistency about when people report. For example, the time point from when they receive their treatment, even the time of day, because we know that there are fluctuations in how people experience symptoms even during the day. In clinical practice, I think it's a little bit more flexible. So the ways that this has been done have been, for example, if it's important to know a patient's symptoms before they come into a visit, the system might be synchronized with the scheduling system. The system will know that a patient's coming in a week, and so that will trigger sending an email or a text message or a phone call to the patient saying you have an upcoming visit, please report on these things. For other patients, we might just want them to do it at the clinic visit, or for other patients, we might want them to do it on a regular basis, in which case they might get a reminder, every Friday or on a day and time of their choice. What this question is asking about, though, is about what we might call solicited versus unsolicited reporting. Solicited reporting might mean that we send a text message every week at the same time to the patient, please report. Whereas unsolicited or voluntary might mean, you know what, anytime something's bothering you, you should report. And a lot of these systems actually do both of those things. They will have regular reporting so that we can follow people's trajectory over time, and we ask people to do it even if they're feeling okay, so we know how they're doing. There may be a question at the beginning saying, you know, I have nothing to report this week, thanks very much, and they're done with it. But we also enable people to report anytime they have a problem, and that closes that communication gap with their clinicians.
Okay.
Yeah.
Well, let's go ahead and wrap up. I've just got a few closing remarks. We want to thank the University Cancer Research Fund and the generous funding from the state of North Carolina to make that possible. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and Alan Brown for all their hard work that makes this possible. Coming up here, we've got more lectures, June 14th. We've got an RN and Allied Health lecture, The Power of Teamwork, Navigating Patients with Complex Needs. And then on June 28th, we've got a Med-Surg lecture, Treatment of Relapsed and Refractory Multiple Myeloma. June 30th, we've got a community lunch and learn lecture, Understanding and Living with Chemobrain. Those all promise to be great lectures. Thank you for the important work that you do, Dr. Bosch. Obviously, based on the outcomes of your research, we can see that this is making a real difference in patients' lives, and we appreciate that and looking forward to hearing updates in the future.
Thank you. Thanks, everybody.
All right. Thanks so much. As I've mentioned, lots of places you can find us. Start with unccn.org. Over 180, I think this will make 188 lectures you can find there. Lots of information about upcoming events. Until next time, thanks so much.